My name's Randy Beranek. I'm President and CEO of the National Psoriasis Foundation. And our mission is to drive efforts to cure psoriatic disease and to improve the lives of all affected. We've been in existence for about 50 years. We're headquartered in Portland, Oregon, but we have a strong presence here in the district on the policy side of things. We've been at it for quite a while and have a really strong team that work on policies and programs and trying to engage investment in psoriatic disease research. Everything we do at the National Psoriasis Foundation is to improve the health of people living with psoriatic disease. That's both psoriasis and psoriatic arthritis. Through our strategic plan to improve research, access to care, and education for patients, providers, for the general public, and obviously for policymakers. We attempt to reduce or eliminate disease symptoms because the patient is on the right treatment, and you'll hear more about that today. We aim to lower an individual's risk of developing illnesses that are related to psoriatic disease by promoting good disease management, but also overall healthy behaviors. Psoriasis affects about 7.5 million people in the U.S., although it's reported less frequently in the African American, Asian, and Latino populations than it is in Caucasian populations. However, a study by the Journal of Drugs and Dermatology found that Latinos, African Americans, and Asians are more deeply affected by psoriatic disease than Caucasians, both on a physical and psychological level. Therefore, the NPF seeks to explore and investigate the prevalence of psoriatic disease in non-Caucasian patient populations and to support overall efforts to improve health outcomes for all people that are affected by psoriatic disease. I would like to thank Congresswoman Eddie Bernice Johnson for being the sponsor of this event. Congresswoman Johnson, who was an RN by trade, certainly understands the importance of psoriatic disease research and for treating underserved populations. We're extremely grateful to her, but also her talented, effective staff that helped us with today's hearing. Today we've got a great panel of individuals I know you'll learn a lot from. Seated closest to me is Dr. Paul Wallace, who's a dermatologist in Beverly Hills, California. In the middle is Jonathan Scott, an NFL lineman and a National Psoriasis. Oh, I'm sorry. You guys switched seats on me. Okay, we put Jonathan on the end because he's the largest living person with psoriasis. So. We're also joined by Dr. Amy McMichael, who's chair of dermatology at Wake Forest Baptist Medical Center. And she's also chair of the Skin of Color Society. And so we'll be hearing from each of our panelists individually. And then at the end, you'll have an opportunity to ask questions of our panelists. So thank you again for joining us today. And please welcome Dr. Wallace.
Good afternoon. Thank you so much for being here today. I'd like to thank Randy for the leadership that he's certainly given the NPF, and very much so for the DC advocacy staff that's worked hard to get you together and to get me across country. It's still morning for me. And of course, I want to give my thanks to Congresswoman Johnson. I was actually here earlier in the year when it got closed down, where it snowed, and being the weather wimp I am, I was more than happy to jump back on the last plane going. But I was sorry that I wasn't able to give some of the message, and I want to talk about psoriasis. I find myself as being just a major advocate and a spokesperson of a sort for patients with psoriasis. It was mentioned earlier that my practice, my cosmetic practice, the one that helps pay my kids' tuition, is in Beverly Hills, but I have a large general dermatology practice in South Central Los Angeles. And you've heard different types of names: South Central, Central LA, Watts, Compton, so on and so forth. And we've had a changing demographic of folks. From when I grew up, Compton was primarily Caucasian, and of course we usually think of it now as being more black African American, but indeed it is primarily that of a Latino, primarily Mexican population. And the diseases and how they manifest themselves, how they look, can be quite different. I was trained at Martin Luther King Hospital, which is right in the center of South Central Los Angeles. And interesting enough, and sometimes people still ask, well, why do you need to have a change, or what's the big deal with the skin of color? When I was doing my residency there, we were actually told that we needed to go to the San Fernando Valley, which was primarily Caucasian, because we weren't seeing enough of certain skin cancers. But that wasn't the other way around. And there's a number of people who aren't able to identify pretty common problems, and for those that can be difficult, they certainly aren't getting the type of diagnosis or treatments that they should. There was a patient who stole some lyrics, or should I say borrowed some lyrics from an old and great songwriter, Curtis Mayfield. And I want to talk to, well, I want to say what they said to me. I heard them once in a patient group that we're doing. It said, "To be invisible will be my claim to fame. A person with no name, that way I won't have to feel the pain. Why can't I be like everyone else, just a plain old human being? Instead, I'm trapped in this skin, and the world treats me so mean. If I could only be invisible, that way I wouldn't have to explain a thing. Of all the daily things that hurt me so, no one will ever know. Inconspicuous is what I pray to be, so I don't have to bear the shame of someone seeing me." And I can tell you that that echoes for the millions, the 10 million patients that, or 10 million people who have psoriasis across the country. They'd like to have an opportunity to be invisible, because there's nothing worse to have a disease that doesn't get very much sympathy. In fact, there's huge pushback from it. No matter how much education you put out there, if you just look at these patients as we go through here, it's hard to believe that that's not infectious. It's hard to believe that you can't get that it's not contagious. And they feel the brunt everywhere. We sometimes forget about shaking hands, or if you're in some of the blue-collar work and you're serving tables or doing whatever, if you have to show this. And I work in Hollywood, and I can tell you when we're filming folks that are with HD, it's hard for the makeup artist to be able to hide this. But it's not so much just the skin manifestation, it's the whole psychological burden of this disease. Ages 3 through 93, although most prevalent between the ages of 15 to 35, males and females alike, but in my opinion, it's certainly a heavier burden if you're female and have psoriasis. What is it? Well, you're being able to see some of it, because I thought that I really couldn't put words to it, and you certainly couldn't feel what these people feel in trying to, at the very least, hide this. It's a lifelong and chronic condition, and we don't have a cure. But we do have quite a few medications that can help control the cutaneous, the skin problem. But there's also an arthritic component. It is an autoimmune disease where the human body mistakenly attacks and inflames or destroys healthy tissue. It is not, and I repeat, it is not contagious. And for those patients who've had it for more than 20 years, the estimate is sometimes 30 up to 50% of them can get psoriatic arthritis. And I know that you usually don't do this, so I'm going to ask for you to join in for a moment. If you could just make a fist with one hand and cover it with the other. And this is how our joints normally move. effortlessly and easy. Now, in psoriatic arthritis, where they have what they call a pencil and cup picture radiographically. So instead of that fist, you take one finger and put it right in your palm, and that's what has to move now. And as you would feel that nail that scratches across, that's what they feel on their joints, their fingers, their neck, their lower back, their knees. Now, one might ask, well, but how bad is it? It's just a skin disease. No, indeed it's not. It is a total body, as I said, autoimmune disease. And it's costing this country, the burden of psoriasis on the U.S. economy is estimated between $113 to $136 billion annually. Now, the research that the National Psoriasis Foundation has done through surveys and telephone calls finds out that usually psoriasis patients have about 6 different doctors that they see before they get it diagnosed properly and treated properly. And I can say that my anecdotal experience in my Beverly Hills office, that's it. But in my South Central LA office, where the income is lower, the insurance is poor, 10, 12, 14 doctors is not an unusual number for these patients to see, and they still may not have the proper diagnosis or treatment. The challenges with regards to the misdiagnosis and undertreatment go hand in hand with people of color. It doesn't look salmon. It's hard to find that on me, where that may be one of the major diagnostic tools that are used by many to determine whether or not a patient has psoriasis or not. I want you to know that beyond just the cutaneous, beyond just the skin, what are some of the things that are associated with psoriasis? When you see the word psoriasis and it goes across your desk, you can think about depression. Why? Because patients with psoriasis have an increased suicidal ideation, a sense of hopelessness, obesity. Other common diseases which are associated with psoriasis: diabetes, hypertension, again, obesity. And you may know or have heard that up to 40 times the risk many of these patients have for having a major cardiovascular event, such as a heart attack or stroke. And on a scale of 1 to 10, in terms of the depression, the average coming to my office is a 9. Fortunately, at this time in history, it's probably the best time ever for someone to have psoriasis because of the medications that we have available. The problem is that a vast majority, I'd say 90% of the patients that I treat in South Central Los Angeles can't get these medications. The barriers and hurdles that are put up by the insurance industry, the sometimes hundreds or thousands of dollars with regards to co-payments, or the minimal amount that they need to reach to be able to get the insurance is something that's completely out of hand. Those patients who are on any type of federal program, Medicaid, Medicare, are almost completely out the picture. Now, one thing that can happen, one thing that clearly needs to happen, is an understanding that these patients are suffering. They're suffering because they'll never have a telethon. It's not going to be a Poplar where they can trot out someone and say, oh, look at this and get. No, they get pushback. They get pushed back by the doctors who don't want to see them. The primary care doctors will not appropriately treat them because their hands are tied. They can't give them the medication they're supposed to have. Right now, I have many patients who are running to Mexico or to perhaps what they call their home country because they can buy the drugs for a tenth of what they can get them here. And there are side effects associated with that. Well, I'd like to finish by saying that the general public sees psoriasis and there's an aversion to it. These patients don't get embraced by organizations. They don't get embraced. Of course, I'm not speaking with the National Psoriasis Foundation, but there's just no love, as that they would say. As far back as biblical times, and sometimes they called it leprosy, but if you read it, it actually was psoriasis, and these people were outcasts, stoned to death. We need to open up the doors, provide some funding and direction for these individuals who suffer, as they say, the best world they could have would be to be invisible. Thank you.
Thank you, Dr. Wallace. Next, it's my honor to introduce to you Jonathan Scott. Jonathan's a 9-year NFL veteran offensive tackle, a businessman, and a health advocate for the National Psoriasis Foundation. Jonathan was first diagnosed with psoriasis in 2009, shortly after the death of his father, and I'm sure he'll share that story with you. He was playing with the Buffalo Bills at that time. After he first was diagnosed, he began to develop a growth on his scalp, and after several tests, it was determined that he had plaque psoriasis. In addition to playing for the Buffalo Bills, Jonathan was also an offensive lineman with the Pittsburgh Steelers, Detroit Lions, and last played with the Atlanta Falcons. He is co-owner of Cole Muscle Cars, which is in Atlanta, and owner of and founder of Zoo Nation Media. Today, Jonathan Scott's also an ambassador for the National Psoriasis Foundation, helping to bring awareness to psoriasis and speaking as a health advocate. Please welcome Jonathan Scott.
So how y'all doing today? Good? Good. I'm sorry, I'm a Texas boy, so I'm a little loud and I'm a little proud. So, you know, first and foremost, I just like to thank the National Psoriasis Foundation for allowing me to be a part of this. You know, psoriasis has become big in my life, literally and emotionally and everything else, you know. Just kind of give you a little background about me. You know, I'm born Dallas, Texas native, so big shout out to Congressman Johnson because she represents great Dallas, Texas. So I'm very proud to say that she's definitely representing Dallas, Texas well. Also, you know, I played in the NFL for 9 years. Graduated from University of Texas, had the liberty of you know, getting my degree and graduating with honors. And I mean, everything you think of is fairy book, you know, fairy tale story, you know. So getting into the NFL, started playing that's roughly about my 4th year in the league. I got this little, I thought it was a ringworm on my scalp. Had doctors looking and they didn't know what was going on. I thought I had some rare disease that was going to probably take me off the planet. At that time, I'm petrified. At the same time, that's when my father passed away, and I was at that kind of moment of just complete depression, you know. And then, you know, one of the things about psoriasis is that when it triggers and it comes kind of full blast. So, you know, it took a while to kind of understand the concept of what is this, what's going on. I mean, you got professional medical doctors don't even know what's going on. So you can only imagine how I felt. So at that point, I kind of had to own up. You know, it's one of the things we do in the NFL, especially offensive linemen, is you got to be accountable for everything. You got to be accountable for your actions. You got to be accountable for your words. You got to be accountable. You know, that's just the standard. So one of the things I started doing is that instead of kind of playing the the pity party. I had to be accountable for the simple fact that I have the disease. Now, so what am I going to do to, to turn it around and use it to my advantage? One of the things I said that I was going to do is be able to speak to youth, speak to people, speak to, congressional briefing, being able to, voice the importance of getting education, getting funding, getting advocacy, getting people involved, because it's very necessary. And why I say it's necessary, and it kind of segues to my next point, is that I'm now working with National Psoriasis Foundation and Leo Pharma, and they're doing a youth ambassadors program. And I tell you, when you actually get to see these kids, and we're talking 9-year-olds, we're talking kids are going into high school. When a kid, if you look at these pictures, there are kids, little children, that are covered from head to toe, at least 90% with this disease. And can you just imagine the emotional, the psychology, the psyche that's going on? We're talking about bullying. We're talking about depression. We're talking about all kinds of things. And the thing about it is like me being in the position of playing professional football, it's my duty to be able to uplift, to be able to give a sense of hope, being able to give words of wisdom to say, hey, there's ways to fight it. One of the big things I tell these young kids is that psoriasis is only debilitating if you make it debilitating. So the whole concept is that we have to one, be knowledgeable. You have to know what the disease is, how it can affect us, how it can be a detriment to our lives, our family members, our friends. It's a disease that's serious, and it's a disease that we definitely can't just kind of pass off. It's definitely something that it can affect your household. It can affect your mental stability. I mean, it can be a detriment. But the thing about it is, if you become knowledgeable, become an advocate, become aware, we can definitely have a stronger force. And I know this is one of the reasons why we're here today. So not to kind of rattle on and on, because I can get on I got a nice little podium here, so I can kind of go on and on. But I just really implore everyone to really get involved. I ask, put time into, get your Google search on, look up psoriasis, look up National Psoriasis Foundation, look and see how this is affecting lives. We're talking millions of people in America living with it, and a lot of our stars and entertainers. It's an everyday deal. So. I just want to say I appreciate your time. I appreciate your attention, and I ask that you really, really, really be a part of this, and let's keep fighting.
Thank you, Jonathan. So now you've heard about psoriasis and how pretty much anything can trigger it. And the misdiagnosis that individuals can have and the challenges that presents. You've also heard about how psoriasis can affect the career of an individual and the amazing changes that happens once a person is diagnosed. Now we're going to hear from Dr. Amy McMichael, who's chair of dermatology at Wake Forest Baptist Medical Center Maya Angelou Center for Health Equity. Her research focuses on hair and scalp disorders and skin disease of deeply pigmented skin. She's a diplomat of the American Board of Dermatology. Her publications include many peer-reviewed articles, chapters, and invited articles on these topics. She's also co-editor of the text Hair and Scalp Diseases, Medical, Surgical, and Cosmetic Treatment. She's also, as I mentioned earlier, she's also chair of the Skin of Color Society, which is a professional dermatologic organization dedicated to promoting awareness of and excellence within the special interest area of dermatology, skin of color. She's a graduate of Swarthmore College and the University of Pennsylvania School of Medicine. So please welcome Dr. McMichael.
Thank you, Randy. And I also want to just extend my thanks to Congresswoman Johnson for really hosting us for this event today. Thank all of you for making it here today. And also, I want to thank, in general, the National Psoriasis Foundation for inviting me along on this important mission. I thought I would start today with sort of introducing you to my journey, taking care of patients with psoriasis, especially in patients with skin of color. When I graduated from my residency training 21 years ago, I was bright-eyed and bushy-tailed, idealistic about what I could do in the world, and I joined the faculty at Wake Forest, as well as began an epidemiologic research program. So epidemiology is the study of populations. So instead of studying one patient at a time, which is what you do as a doctor, I was going to study the big picture, populations. So I had to decide on a thesis, and I thought my thesis would be psoriasis and skin of color, because all throughout my residency, I had seen how much these patients suffered and how they'd been misdiagnosed. So I told my advisor, I'm going to do psoriasis and skin of color. And he said, that's a really bad idea, with an emphasis on bad. And so I kind of gave up the ghost. I didn't do it. I listened to him. And the reason he told me it was a bad idea is because he had been an internist before he came to teach epidemiology at the school. And he said, and I practiced in South Carolina, I never saw one black patient with psoriasis. So I don't think you should say it, because I don't think it happens. And I'm thinking, okay. Well, he never entertained the idea that maybe he didn't know how to diagnose psoriasis in skin of color patients. Or perhaps he didn't know how to diagnose psoriasis at all. And I was so young, I kind of let it all wash over me, but I never let that sort of kernel of excitement leave. So years passed, I saw lots of patients coming in diagnosed with lupus, with eczema, with anything you can think of, vascular diseases. I've even had patients who really had psoriasis be told that they were causing their own skin disease by picking at the skin lesions, and that's why they looked the way they looked. And so I finally got excited and said, you know, I'm going to go ahead and do this work. Meantime, there were some other researchers looking at this work. One of the biggest psoriasis researchers, Dr. Joel Gelfand at the University of Pennsylvania, and his group started looking at, with the help of the National Psoriasis Foundation, at populations, both Caucasian and African American, to see really how many people really do have this. And they came up with finally the prevalence of the disease. We thought it was probably around 0.7% of the population in the US, but actually it turns out it's about 1.3%, or closer to 1.3 or 1.5% of the population, versus 2.3% of the population who are Caucasian who have it. So a lot more than what we originally thought. And that was great data. And what they also got out of their study was that the extent of the disease, how much of the skin is covered, seemed to be more in African American patients. But we still didn't quite have all the pieces. So I still had that kernel, and I went for it. I tried to figure out, how can I do this study? How can I get this information out there? How can I learn more about why would the extent be worse? Why are we not diagnosing it? So I decided I would go to NPF, because that's a good place to start when you want to do some psoriasis research. And I said, can you guys tell me if maybe DC or one of the places where your support groups are really big, you have patients where I can do some research? And they said, yeah, we got a big support group there, but not so many with skin of color. And I was like, oh, okay. So they weren't there. So I went to a manufacturer of one of the drugs, like the top drug at the time for psoriasis. And I said, hey, you guys did these huge pivotal trials for the FDA, getting these drugs approved for psoriasis. Can I look at your study population and look at the black folks and see what, is going on? And they were like, yeah. So, yeah, we don't have too many of those in that study. Yeah. So I thought, well, how could I do this study? You can do one off in your office, but it was kind of more like the same, as what my South Carolina friend, whatever I would see in my office might not be representative. So I finally figured out a way to do that study. I said, I'm going to get in touch with the providers that take care of patients with skin of color who see psoriasis. So I sent out a survey to 29 of these providers, and I'm sorry I didn't know about you then. I would have sent it to you. This is a little ways ago. And what we found out was some really interesting stuff. We all did use the same kind of thing that, you know, everybody uses to diagnose the extent of disease and severity of disease, where we look at the scale. You can see all that on these pictures. We look at the extent, how much of the skin is covered. We look at, you know, maybe some thickness of the plaques. You know, some people have thin plaques, some people have thick plaques. And we look at redness, and Dr. Wallace talked about that. We look at redness, and that's great. Okay, that's how we look at it. But one thing that was different in these providers that I surveyed was that they used pigment. They use what we call dyspigmentation, or when the skin gets too dark or too light from inflammation or damage, and that happens to huge extents in people of color for all the diseases that affect our skin, but particularly in psoriasis. And this is very disfiguring, it's humiliating for patients, and it's very difficult to treat, and it's long lasting. So even after you treat the psoriasis, that pigment stays around for a really long time. And that is something that we don't use in our scales. So if we're using a scale to determine how extensive disease is, to say, okay, you can get this drug, and pigment's not on our scale, but redness is, oops, I can't see redness in your skin, well, you might not get that drug. And how about if you're going to get in a study, clinical trial, and we've got to do this specific sort of little measure of what the skin looks like, and there's redness in that scale but no pigment, well, you don't get in the clinical trial either. And that's why we need your help, because we need to start looking at assessment tools. We need to start looking at populations in a different way, to turn it around and look at the things that really are going to help us decide what is truly the burden of disease. So, you know, so we're sounding the alarm here, as you can tell. You know, we're talking about skin of color, and why are we doing that? And part of the reason we're doing that is because we know from the U.S. Census that by 2050, half of the population is going to be skin of color. And it's not just African Americans, although that group is growing. One of the biggest groups that's growing is Hispanic patients. And we know also from some studies that Hispanic patients come in, and one of their top 5 conditions, actually we did this study in our medical center, one of the top 5 skin conditions that they're concerned about is psoriasis. It's actually not, you know, in African Americans, Caucasians, and Asians, or Pacific Islanders, but in Hispanic patients it is. So we got this growing population who they're already, one of their top 5 skin condition worries is psoriasis. We're going to have to be dealing with this. You know, by the time 2050 comes, we're going to need more doctors who understand how to look at this in skin of color. The other thing that we know from that work that we did with a group, Dr. Steve Feldman and myself at Wake, is that Hispanic patients and Black patients are a lot less likely to see a dermatologist if they only have a skin problem. They go see their PCP. They go because that's what they have access to. So that's a big problem, and we're going to have to change that, because they're going to get diagnosed with the picking disease or with eczema or whatever have you, instead of getting diagnosed with psoriasis and getting the correct treatment. So those are some of the things that, you know, I really wanted to talk to you today. I've talked to you about sort of population science, the burden of disease, what we need to do to sort of impact clinical trials, that sort of thing. The last piece of the puzzle that I just wanted to talk to you about is looking at this from a supply and demand point of view. And that's when I put on my hat as the Skin of Color Society president. And that is that we need to look at how we're going to really support and promote getting patients what they need, especially when there's so many health disparities. And one way that we're going to do that is by providing more of a pipeline of skin of color physicians. We know from lots of research that skin of color physicians take care of skin of color patients. They are more likely to be in those communities, like Dr. Wallace just talked about, in those medical centers where they're going to be able to lend a hand to those patients. So we need to start looking at the fact that since 1974, we have not had an increase in African American men going to medical school. That's really, really sad. It's sad and it's frightening, because people are not going to be taken care of if we don't do something about this. So with that, I want to tell you that, you know, we are going to work with all of you, whatever you need us to do to help you understand and get you educated up to the level that you need to get to help us. We're going to keep pushing. We're going to keep doing clinical trials. We're going to keep thinking of ways to help our patients. But we do need all the things that you guys provide for us here in Congress to get some of that work done. We can do a lot of it in our offices. We can do a lot of it in our research labs. We can do a lot of it, you know, going out and giving talks to medical students, but we just don't have the piece of the puzzle that's sort of the public policy piece. And so that's what I'm hoping we can get by coming here. So I think that's a way that we can eliminate health disparities in patients. I think it's a way we can increase diversity in our physician population. And it's a way we can really take care of psoriasis the way that we really hope to be taking care of it in the future. So with that, I thank you.
Great. I'd like to thank our panelists, Doctors Wallace and McMichael and Jonathan Scott, but also Congresswoman Johnson for sponsoring today's event. I've spent time in many of your offices, and the one thing that I've learned by doing that is that you all want to help. You really genuinely want to help, and you're probably sitting there thinking, what can we do to help? And there's really three things I want you to take away today. To talk with your boss about the Patient Access to Treatment Act, the PATA bill, House Bill 1600. There's 95 co-sponsors in the House. The bill amends existing laws related to cost sharing for payers that are putting specialty drugs into, and the bill causes payers to put specialty drugs in the same tiers as non-preferred prescription drugs. So that's an important piece of legislation. Second of all, to ask your boss to support increased funding at NIH. We talked from the outset that we're in business to find a cure to psoriatic disease, so increased funding at NIH is important to have more funds available for our researchers to compete for. And then finally, in FY10, we were successful in achieving an appropriations from Congress for the CDC to put together a public health agenda on psoriasis and psoriatic arthritis to identify the gaps in treatment and education across all communities, including those of skin of color. That funding led to the public health agenda. That funding has run out, and we continue to come to the Hill looking for appropriations so that CDC can start implementing the recommendations that are in the public health agenda. So the agenda is already set, but we need Congress to take action to appropriate funds so CDC can take action on that agenda. And so if you can do those three things with your boss, it'd be a great benefit to our community, and appreciate your time today. Thank you all for being here.